We're back. Not sure what just happened, but we're back on. Let me send Dr. Oh, there she is. Okay, good. I'm not sure what just happened, but let me. We're back. Welcome back, everyone. Welcome back to week 3. And Dr. Collins should be. Oh, joining us shortly.
I don't know what is going
Okay.
on. They don't want us to go live. They don't want us to be great today.
They're right. They don't want us to talk about suicide prevention, but we're going to keep on talking about suicide prevention
Exactly.
and suicide awareness because that's what
Yes.
we're about to do.
Shame on you,
So,
Instagram.
yes, they ended our session for us and we did not ask for you to end it. Please do not end my session ever again unless I ask you to. Thank you very much. And or unless I have some copyrighted data, which is this is our intellectual property. So
Exactly.
pause. That part. Now, you were saying about, or I was saying the fact that no, a device outside of usage is not a true determinant for depression or anxiety or suicidality in itself, right? It is user controlled or user derived, user attached. Yes, it also could be used as a weapon. However, mostly a device is user attached. And so when speaking about vicarious trauma through social media, mobile phone, yes, that is a means where someone can receive, right, the feedback that can contribute to that individual experiencing vicarious trauma after suicidality or suicide. Um, yes. Now, that brings us into the one avenue of vicarious trauma that I want to speak to as myself and yourself as clinicians.
Okay.
Now, yesterday was Physician Suicide Awareness Day, right? So there is not a Suicide Awareness Day for healthcare professionals as overall, like an overall arching Suicide Awareness Day. However, right, this is Suicide Prevention and Awareness Month, but because a physician is a provider, I'm lending ourselves, and again, you're doctor prepared, so you fall into this criteria. Period. I don't as of yet. However, right, this is something that I do still say I'm lending myself to, and the reason for that is because it gives us an opportunity to look at how ourselves as clinicians might be more at risk for suicidality for the simple fact that we are clinicians. What do you think
Yeah,
about that?
no, you know, I don't I don't think a lot of people take in consideration of the type of work that any type of clinician do, whether it is a counselor, nurse practitioner, a nurse, a physician, psychiatrist, psychologist, all of the things, because we are in the field of helping people. um and then when you have a system that governs you in a career field, there's a lot of different factors that a lot of people don't consider when we're talking about our health, our well-being, our mental state. um and so I do feel that we are at a higher risk, not only because of all of these things that the system kind of put a hold on, place on
Place.
us. Yeah, but also because we want to help people. And when we feel like we're unable to do that, then that is what our job is really to do. And when we feel like we can't, it's almost as if we're failing. So I agree 100% that we are at a greater risk in any capacity of a clinician, for sure.
Yes, yes. Thank you for saying that because, definitely doctors, definitely from the doctor to even. hospitality
Wow.
staff in a hospital, right? Anyone in a hospital that has direct patient care or direct experience with a client of some sort, potentially can experience this pressure,
Mhm.
right, to not fail. And so that is definitely something that I think that it's not spoken of a lot. And one of the things that I want to bring up specifically to that point is the fact that lately, since I wouldn't say COVID, there's been a lot of initiatives to remove some of the institutionalized verbiage and jargon that is required within medical boards. Now, I do see that it's spidering out into the other allied fields, like therapy, uh, physical therapy, nursing. I do see that it's happening, not as fast as it's happening in the medical field as far as for
Yeah.
physicians. However, it is happening, and I think that is important. And what that is aiming to, because remember, right, if you are a clinician and you are experiencing, let's say, suicidality and or impulsive thoughts that could be a reason why you would be diagnosed with an illness that is unfavorable to you, if you don't disclose that, then that might put your license at risk, right? So that prevents clinicians from, disclosing that. And so when I was, reading the data, a large determinant of reasons why some clinicians do not seek help is specifically due to that. And
No,
what are your thoughts?
I mean, I was when you said that, I was thinking about the doctor, the physician that you shared with me, Dr. Lorna Brand, and I hadn't heard about her story, or at least I didn't think I did. And after I read her story, I was like, actually, I did read this because it was all over the news during COVID that the physician died by suicide. And so I didn't really look into her story until recently. And to your point of this, the board, them having to disclose to the board, that's something that had written up about her. And as she was dealing with COVID within itself at the hospital, then she contracted the disease and had to deal with it with her own on her own. Sorry, and then 24 after that moment of the 24 hours of no fever, she went back into work, and then she started having these depressive spells to where she couldn't even move. But what was interesting when I was reading it is that they were saying that she was talking to her family members and was telling them, like, I can't. Once her sister took us to the hospital, that she said that she couldn't go back to work because now that she's been admitted, her career is over. And I honestly didn't
Over.
know that physicians had to report that, and that the system is created to really stigmatize mental health, when that is a big part of who we, like, our mental wellness is a part of who we are as a body, right? It's not just our physical wellness.
Exactly.
And for them to separate that and demonize it as if something is wrong with you and you are in no way capable of getting better to help serve and do your job, that was really weighty on her. And they believe that that was a contributing factor
A
of
cont-
her.
It was a
Yeah.
determinant. Yes. She was the director of the
Yeah.
ER, right? And so you're a director of the ER. You now have been admitted because of your own like mental illness and or physical illness. Everyone in her mind, right? Everyone, and it's not saying that it's not true, because clearly that's what happened. Everyone knows about this. This is now part of your record. So now then, what is the next
Yeah.
step for you? So for many clinicians, that's the
Mm-hmm.
thought that prevents them from, one,
Mm-hmm.
seeking care, and for two, sharing about it, right? Because imagine if you are the sole breadwinner for your family and you're a clinician experiencing suicidality, and you know that if you disclose this suicidality or disclose this, your family loses their funds or they lose their resources, then you're more likely, the risk for suicidality for you or for that person goes even higher. because now not only are they have the pressure of their thoughts, they have it's like a siloed
Mm-hmm.
aloneness, right? It's a degree of aloneness that only a select few of individuals can even receive. Because if, let's say, you don't trust one of your colleagues, or you don't trust a peer that you work with, no, you're not going to bring this up, and you also can't bring this up to your family, because then what is your family going to do if you're not able to take
Mm-hmm.
care of them? So this fact specifically contributes to the degree of suicidality amongst
Mm-hmm.
clinicians. And then, right, there's the piece that I think that we don't speak about enough. What happens to all of the individuals that this clinician was taking care of, this clinician was working with? And that is the place where vicarious trauma becomes something that is
Yeah.
mountainous. And what are your
No, I didn't think
thoughts?
about that piece. That's a good point that you made of how her clients or her patients would have experienced vicarious trauma. I know that the video cut off, but for those who are joining in, we are talking about vicarious trauma and how it impacts us on a daily. And with considering that, I can only imagine with people who are already suffering and dealing with their own ailments and diseases and their
Hmm.
own traumas, to take that on. It now puts me in a position to think about, I have not, thank God, but I have not had a client to die by suicide or to die. Oh, actually I did have one to pass away. But taking that on as a clinician is one thing, and then to consider how that would be for a client who is relying on this person to help them, and that is no longer here, and learning of that, what that would do to them is, I can't even imagine. But yeah, it shows up in these ways. But what do we do with that, right? How do we help people through that? Do people even know to talk about that? Do people even know to associate that pain or that absence as something that they're dealing with in their life, that's contributing to their own depression or their own trauma, or their own regression if they're having any? I don't I don't think that I've ever had a conversation about that, to be honest.
So most times, right, the funny thing is, most times when, or not most times, a lot of the times when I was in working in the critical care unit, if someone passed away, we there would
Mm-hmm.
nothing happened. We moved right on to our next client, our next patient, our next scenario. And the problem with that is we don't talk
Yeah.
about it.
I've always wondered how. I've never worked in well, I've worked in a psych unit, but never in the other units. And so I don't know what that's like, but I've always wondered the experience of clinicians, nurses, physicians, that it seems as if you guys have to normalize death.
It starts becoming a part of your job. And that is another determinant that increases the risk of suicidality amongst clinicians, specifically like the clinicians that have access to
Mm-hmm.
lethal means, like nurses, or internal physicians, anesthesiologists, or nursing anesthesiology, right? These individuals then have lethal means of access to harm. And
Yeah.
they have means. They have the means to access these supplies, and so this is a factor that is a large risk. And so perhaps we haven't seen a lot of like Swiss cheese events where these individuals are taking their lives using hospital based items. It can happen, right? There are some scenarios where we have seen it happen, but it's not to the degree that we
Yeah.
know about it by name, right? However, no, due to the fact that it is normalized for death to be a part of our profession, then what do we say? Do we say that vicarious trauma is just a part of our lives and do nothing? Or do we even speak to it? I think that one of the first steps of even speaking about the effects of vicarious trauma, specifically related to suicidality, is being
Mm-hmm.
aware of it. And I think that that is one of the first steps to go on to proceed. That's the first step. If we don't even know that it's a problem,
Right.
how can we address
Right.
it?
Absolutely. Which death is normal. We know that that happens. But like you said, being aware of what's going to happen, there's a difference between knowing that death is normal and that it will happen at some point in our lives, but being in this role as a provider and not talking about the effects of it is when I believe where the problem lies.
It's risky.
Yeah.
It is very
Yeah.
risky. Lately, lately I've seen a lot of, and I haven't been at the bedside for about 5 years. As far as my last critical care shift was in um, the beginning of 2020, right? So almost 5 years, right? So I haven't been at the bedside as a practicing nurse. I have, worked in hospitals by different means, but I have not been a practicing nurse since at that time. At that point, they were starting to do debriefing sessions, RCAs related to a death, or even crisis therapy sessions for the nurses or for the individuals that are involved with this person's death. But if you think about it, it wouldn't only be for the primary nurse. It could be for anyone in that unit. It could be someone who's taken care of that patient on another day. It could be transferred as far as even to the lab technician who took care of that person and drew blood at any particular instance in this patient's
Mm-hmm.
care. So the degree of spread of the potential vicarious trauma related to normalizing death in a hospital setting, it's profound. And so because it's so profound, then when we're speaking about clinician suicidality, we also have to use that same means to address physician and clinician
Mm-hmm.
suicidality. And I say that meaning, let's say, for example, you have a clinician that is experiencing suicidality. Would you only speak to the clinician about their suicidality? And I would have to
Right.
say no, right? Yesterday, as I was sitting in on UCLA Ground Rounds, Harbor UCLA Ground Rounds, and I was listening to Dr. Myers speak, they're bringing up a concept that's called like a tumor board. Like when, for example, someone who has a tumor, they are seen by perhaps multiple different oncologists, multiple different specialties to figure out a dynamic approach to address that illness. But when we come to psychiatry, psychology, that is not what
Mm.
happens. And so within that space, we have a Swiss cheese effect where there's all these holes. That what happens if one of these holes should line up? Then it makes that person, if they're being seen by a clinician, right? Because they might not even be seen by a
Right.
clinician, makes them more likely to
Yeah.
be at risk for suicidality. And that is something, what are your thoughts about
No,
that?
that makes that's makes a lot of sense. And then that leads to the question of what do we do, right? What do we do to try and fill those holes so that this does not become an issue um, in our field? Because I could definitely see how that plays a role even, but like I was mentioning earlier, like that's the system that we are fighting. Um,
That is a
and
system.
and
It
that
is a
is very
system.
hard. Of course, like I'm a part of this therapy group, and they're talking about clinician therapists and social workers getting unionized because of the way that the system is really fighting against us to render care, starting with insurances, which is a whole totally different scenario. But no, that's a good
But
point that you brought up.
even that dynamic, right? Even the fact, for example, as a clinician, as a therapist, right, as a provider, doctorally prepared provider, you provide a level of care that is more dynamic, more comprehensive than other clinicians, right? However, when you're reimbursed, are your reimbursement rates reflective of that? Do you find?
Not as it's slightly depending on the specialty and depending on the payer.
Payor.
Now, is it
Okay.
reflective of what I'm worth? Absolutely not.
There, that part. That is what I'm saying, right? So then you have the disparity of a clinician who's spent so many years working and studying and not receiving the compensation, whether that might be
Right,
credit or
right.
financial, right? Those are the determinants that contribute to the suicidality, the burnt out, the fatigue, the inefficacy, the lack of wanting to leave the job, the lack of excellent care because of all of these dynamics. And those factors aren't really
Mm-hmm.
addressed, even though if it's an institutional um, derived, it comes from
Yeah, yeah.
above, right? If it was treated differently systemically, perhaps then the clinician might receive it also differently. But these are determinants that contribute to clinician-based
Mm-hmm.
suicidality, clinician-based burnout, clinician-based fatigue. I'm going to say it again. Just because we overlook that the cause of these things, and when then they start to
Yeah.
pile up, you have this snowball effect of factors that then makes this person more likely to be at risk for suicidality
Right.
or these thoughts that can then turn into actions. Now, when you say about unionizing, I think that it's a good
Yeah.
it's a good
Yeah.
step because then it means like as a group, individuals are coming together and seeing that this is above us, this is a systemic
Yeah.
concern. And I don't know too much about unions, to be quite honest with you, and so I won't speak to unions. But what I will say is it is effective when groups stand together to speak about
Mm-hmm.
common concerns. And so I do think that that is also why institutions are changing the way that these intrusive questioning or the intrusive questions are asked. Specifically because if you figure the questions that are asked for providers, nursing specifically, and even to attain a DEA license or physicians, it infringes upon someone's American with Disability, the American with
Mm-hmm.
Disabilities Act. But
Yeah.
yet it's overlooked. It's ignored. That's not even considered because as the American with Disabilities Act states, an
Yeah.
individual does not have to disclose a disability. However, the boards require these they ask that these questions and you have to certify by perjury or of law whether or not
Yeah.
this occurs, this that are you have you suffered a xxx in this period of time. Now, for some individuals who have experienced suicidality before they attain their licensure, they might have more of a leverage. But what if
Mm.
this didn't occur? What if someone experienced suicidality after they attained their licensure? Is that person likely to speak up?
No.
Go ahead.
Well, and I'm wondering, like, what is that? Are you familiar with that process? Like, what will happen if you do disclose after the fact, and what does the board like? What is that process of the board determining whether or not you can keep your license? Is that?
Yes, so it starts I call it an investigation. It starts an investigation to your fit for duty, your ability to be able to provide care. So imagine with Dr. Lorna Breen, she perhaps conceptualized that this would remove her whole career because if she's suicidal, not able to practice, or having these active suicidality thoughts, when she goes to renew her license or when she goes to speak to her board, can she say, no, I did not experience this last year or in the period between my last renewal and now? yes, she could say no, right? But then that whole dynamic of guilt, of weight, mental strain will still remain because she knows that that's
Yeah, and then it's
inaccurate.
the what if? What if they find out? What if some kind of way they can get this information and then I'm really going to be doomed? So that's going to be over her head or the person's head as well. Wow.
And I was also looking at the data, and it says the less than or more than 15% of physician provider clinicians who have taken their life by suicide in the recent past, greater than 15% have not had one encounter with a psychiatrist, a psychologist, any
Mm-hmm.
mental health professional. So now think about this in the arena of physical health. Let's say, for example, a clinician is diagnosed with
Mm-hmm.
cancer. Do you think that it's likely that that clinician won't be seen for cancer by a
No,
specialist,
they
by the
will.
top specialist, right? Because they know that that's a scientific approach to
Right.
addressing cancer, right? However, why is that not the
For
same
mental health.
in
Yeah.
psychiatry, in mental
Yeah.
health?
Because of the stigma. And I think that that speaks to what we're doing, talking about it, bringing awareness to it, normalizing it so that we can go and receive help. DJ Twitch, I was reading his a write-up with him, and his in the statement, his wife stated that he had never gone to see anybody for any signs of depression, that he was feeling heavy and depressed, but he kept it to himself. He's never had any attempts of suicide before, per her report. But, she said that he had never gone to the doctor. But of course, if we're honest, the way that mental health has been shown or perceived
Perceived.
has been
Yeah.
so negative. Um, Even in the
So, so
theaters, like
negative.
in movie, in film, it's seen as very demonic and possessive. And the hospital is super scary. And so people are afraid to talk about that, or something is wrong with you in a sense. Um, yeah,
Yes. Even I mean, like, so I typically do not like
yeah,
to use the word crazy. And I say
yeah.
that I don't like it at all. And
Bless you.
excuse me. Thank you. Now, the reason why I say that is because crazy means, what does crazy mean?
Like out of your mind.
Right? Perhaps. For sometimes crazy can be an actual DSM-5 diagnosis, but other times crazy can be something that's a
Hmm.
descriptor. So how can we differentiate crazy versus DSM-5
True.
crazy, quote
Right.
unquote? And then is it okay that we're calling
Hmm.
someone that?
Yeah. And where did that even come from to, well, and I'm thinking about, like, even with how society has associated it, like I just said, like out of your mind. But that's also a part of the problem, because like you said, like it can be a descriptor to the DSM, but then also it can mean like loony or something like that. And that is
Yes,
not the depiction of a person who might be suffering from a mental illness.
exactly. Like
Hmm.
the adjective of the adjective
Yeah.
of anything
Yeah. Yeah.
is this, right? So for example, that the weather is, I'm going to use an adjective, that this adjective
Hmm.
in the DSM-5
Hmm.
criteria.
Right.
How is that,
Right.
right? How is it that we're now using actual diagnoses to describe or give the attributes of someone or something? And these are stigmatizing pieces that we even don't even we
Yeah.
overlook. Just existing, we overlook that these are the things that perpetuate
Right.
stigma. So now, if I am someone who says the
Hmm.
weather is bipolar,
I was just thinking about that
right?
example because that's what people ran. Oh, they ran that one down.
Yes. If the weather is bipolar, right? Bipolar-y, bipolarish, then what is a bipolar person?
Right.
right? And so but these are the things that perpetuate stigma.
Mm-hmm. Absolutely.
Because when we allow for the space for it to be demonized or not actually seen
Right.
as an actual
Right.
illness, like these are actual illnesses that individuals do not have full control over, just like someone that's like going to say that
Yeah.
weather is such
Right.
diabetic.
Doesn't even make sense. Right.
You wouldn't say that. You wouldn't say that the weather is diabetic, or you wouldn't say the weather
Right.
has a broken arm. I mean, yeah, you probably could, but again, those are diagnoses. So using diagnoses, it's favorable, or it's very common to use mental health diagnoses to describe things, describe persons, not keeping in consideration that that specific action is what is perpetuating the stigma and also then increasing the risk of someone hearing that, especially if they might be experiencing that symptom, and especially if they might be also contemplating suicide or having
Right.
suicidal
Right.
ideations.
Yeah, that's true. Right.
So
Right.
we don't know.
Yeah. I mean, this is good to know and good to talk about because we don't realize, like we were talking about the Swiss cheese, like the different holes, or the different factors that there's not, there's never just one thing that a person is dealing with that causes X, right? Or Y. But
That's like,
even this
mhm.
alone is something that we can do as a people without getting big systems, big unions, and all of those things into place because now we are not, we're helping ourselves, we're helping society not perpetuate the stigmas of mental health when it's not favorable to the people because now if we make it seem as if it is these are things that people go through and we can work it out, then they'll be more likely to go and receive help.
Very, very true.
Yeah.
Very, very true. Especially because many individuals actually
Yeah.
experience suicidality and they might not even know that it's
Yeah.
suicidality. And that bring first of all, I want to say that is the reason why
Mhm.
postvention is important. And so I'll definitely talk a little bit more about postvention later, but
Yeah.
suicidality that's unknown. And that's like
Yeah.
passive suicidality, right? So I actually made a list that I want to even let me
Okay.
share it. Yes, the different things that individuals might not even know are passive suicidality,
Mm-hmm.
right? Let me pull it up. I can just tell you some off the top of my mind. But for example, I wish the bus would just run over me, or I wish I didn't wake up
Mm-hmm.
tomorrow, or I wish that um, you know if 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 I were to fall off this bridge or fall over and die,
Mm-hmm.
that would be okay. These are not active, these are passive suicidal
Yeah.
ideations,
Yeah.
believe it or not, right? Now, no, they're not actively suicidal, right? However, that verbiage, that mentality, that is actual
So
suicidality. And you then
so
can,
what
mhm.
you're doing, I was reading in our notes and you were talking about how even clinicians, mental health clinicians are not trained in suicide. And I
Yes,
would like to say that that is very, very true. Like I had to go out of my way to take multiple trainings on suicide. And the very first time that I took a training, I felt so uncomfortable, so uncomfortable. But I was working at an organization here, and aside from all of the other factors of the stress that the job brought, what I realized being a leader in in the role that I had, having people under me who had to go out and provide services to the community, these folks were not the ones who are my staff were not really trained in how to deal with someone who was actively suicidal. And that was a problem for me.
So imagine that. Imagine that. The individuals that are actually treating mental health aren't being trained in suicidality or managing suicidality, right? Like, so then what do we do
Yeah.
now? What's
I mean,
next?
we have to get
And
them trained.
we have to get them trained. There's a lot of different programs like first aid, suicide first aid, or psychiatry first aid, or first responder first aid for suicidality, and PQR type of response for suicidality, PDQ also response. But my point is, there's so
Right.
many different acronyms,
Right.
and we don't even know what it means. So,
Assist is also another one. And I really like, it's expensive and it's long, but it was really good. But you're right. You're right. There's a lot of things out there we can throw out, but we don't even know what they mean.
right? And I only say that to say I can say like ABCD. We like,
Right.
what does it even mean? So I think it goes back to clinicians remembering the basics of what we were taught, like on
Yeah.
day one, vital signs,
Mm-hmm. Mm-hmm.
right? We all have a knowledge that every person that we talk to has to
Mm-hmm.
have some degree of vital signs.
Mm-hmm.
And what are those vital
Mm-hmm.
signs? Meaning, if that person has any change in their vital sign, if that could be their heart rate, their breathing, how they're looking, how they're like their pallor, like we have
Mm-hmm.
to pause and stop the way that they're talking. If those simple pieces are
Mm-hmm.
off, right, then there's a likelihood that there's some other way or some other thing
Right.
that we should assess. We should
Mm-hmm.
assess further. And I think that as clinicians, we're not taught,
Right.
suicide vital signs. And I think that if we were taught suicide awareness vital signs, there might be less
Yeah.
suicidality. I can't say that because, right, suicidality is an intrusive thought that sometimes individuals cannot, most times, individuals cannot control
Mm-hmm.
intrusive thoughts. However, oh, no
Uh-oh, I can
volume.
hear. Does anybody else having issues with the volume?
However, is anyone else having issues with the volume?
Okay.
Cool now. Okay, so now, so the thing is, with them, with providers itself not being aware, I think the first then step is also to be aware that we
Mm-hmm.
are not aware,
Mm-hmm.
right? And so then coming in, bringing programs, bringing awareness to it, and that all stems from education, speaking about it, showing case studies, individuals who have either experienced suicidality, had suicide attempts, family members like we had last week. We had, tell me, well, I forgot her.
Oh,
I forget, but tell me
Waukesha?
your Waukesha. Yes, Waukesha and her brother telling her story, last week about her brother passing away from suicide. Those are the type of things that help to
Yeah.
decrease the likelihood that suicidality or the effects of suicide
Yeah.
goes unnoticed. And so I definitely am so thankful that she came to speak and to
Mm-hmm.
share her story. But it also then uh, requires us as clinicians to
Right.
go to that next step where we speak to the fact that suicide prevention, and I know we're almost to the end, but suicide prevention is not
Yeah.
an idea. Oh,
Mm-hmm.
it's not an idea. It is the act of preventing one person, one
Mm-hmm.
human, one life from being lost,
Mm-hmm.
right? So even though we speak about suicide prevention on a mass scale, what we're really saying is we would like to prevent one
Mm-hmm.
person from harming themselves, from dying by suicide. We want to stop that
Yeah.
one death. And yes, we can multiply that. But when we forget that suicide prevention is preventing it in
Mm-hmm.
a human, an actual person that is living, that we speak to, could be our postal worker, could be our driver, could be our teacher, could be our doctor, could be our child, could be anyone, right? And we see suicide prevention as an idea, then we are unable to address it. So, I mean, I don't know if you've heard of this thing, like if you can seek to help a lot
Mm-hmm.
of individuals, but if you're not specifically focusing on a one
Mm-hmm.
person, you end up helping
Mm-hmm.
no one.
Mm-hmm.
And that is what I think the arena of where suicide prevention is going
Mm-hmm.
these days. And as for me, it is alarming and concerning, because then I say, what are we
Yeah.
really preventing? If we're going to champion suicide prevention, what are we really
Mm-hmm.
doing?
Mm-hmm.
What is it that we're
Mm-hmm.
actively doing? And unless we can bring it back down to that single unit of humanism, the vital signs for one person, then how can we even address it?
That's really good, and it takes me to our conversation from last week. And I really, really loved how you took the time to ask her about her brother, because what you were doing in that moment was humanizing him. Though he had gone physically from the world, you wanted to bring the light to who this person is, and that makes 100% sense to me. Um, and we are, I think that this is important, not just for people who have licenses or who are clinicians, but everyday people, because clinicians can't reach everybody, right? We're in an office or at a
No,
hospital or at a school or whatever, but you have people who are walking by you every day. You
every
have
single
people who
day.
are in the stores with you, and I think that everyone has a responsibility to be able to identify and know those suicidal vital signs to be able to help at least one person. Yeah.
Exactly. And I think that's where
Yeah.
we're forgetting, where we're not addressing. And that's why I believe the rates of suicide are rising. We aren't treating suicide as if this is something that
Yeah.
affects everyone. We are saying that suicide only affects X
Right.
population,
It's
but
not.
that is not the case. Suicide does not discriminate based on race, gender, creed, financial
Nothing.
status, dominion, religious
Nope.
belief, right? Language. It does not discriminate. And once we can step into the shoes where we understand that suicidality can
Mm-hmm.
affect anyone, then we can say this is a
Yeah.
global
It
public
is.
health
It is.
initiative. And when we accept it as a global public health initiative, perhaps from the trickle down effect, there can be
Yeah.
change. But in our communities, if we do not see the large global trickle down effect, what we then have to do is
Yeah.
turn it upside down, turn the pyramid upside down, and make sure that we are the trickle up
Mm-hmm.
effect, which means, wait a minute, yes, now
Right.
no one's perfect, right? Can I say that something I've said, an action I've done, might not have contributed
Yeah.
to someone's suicidality? No, that's
Right.
impossible, because you don't know what it is for that person that you know decided their choice to take their life. That's their choice. I say that very significantly because no one can speak for
Right.
anyone else when they're in
Right.
that position. So, but what can we do? We can be aware of the fact that suicidality is something that can be present in anyone, anywhere, any moment, anytime. And once we then can realize that, then we can actually address it, in my opinion.
No, that's
That's just
good.
me.
That's good. That's a good place to end. That's really great. I agree with you 100%. Let's begin to humanize this suicidal initiative, to be able to help people and not make this just a check in the box, so that we can have a decrease in what we're seeing, because we are seeing an increase in suicide. So this was really good. I hope you guys were able to take something from it. Nurse Rose, let us know what we can expect next week.
So next week is our last week, right?
It is
Am I correct? That's our last week. So next week, I want everyone to tune in because I definitely want to share a very humanistic view of suicidality, and that will be next week on our final episode. So you're not going to want to miss it. Trust
it's
me.
gonna be good.
Um, you're definitely not going to want to miss it because I think even listening to Dr. Myers, the percentage of suicide related deaths are um, rising, but rising even more in female
Mm,
clinicians.
wow.
And once we ignore or not even touch that, and why, we get into a very scary, dark place. And so, as a community, right? And so, next week you can expect a very humanized view of suicidality and where
Yeah,
we go from there.
it's so powerful. Bring your tissues. I'm gonna have mine just in case. You never know. You might not need it, but you might.
Yes. Yeah, and sometimes you say that you can get desensitized from suicidality or thoughts or stories of individuals that have thoughts of suicidality. However, I'm not at the point that I'm not at that point.
I,
That is not me.
but I think just as a natural, like I am very empathetic and I'm a feeler, and so I, in the first weeks, I know we're a little over, but I know in the first weeks we talked about how Nurse Rose and I connected, and it was because of this, and we're in it together now because it's just so beautiful. So
Yes.
please tune in next week. It's so
Don't forget to tune in
powerful.
next week.
It's not just a story to only humanize, but to humanize to empower. Because that's what you'll leave with.
Exactly.
So yeah, can't wait to see y'all next week.
Thank you. Thank you everyone for
Bye. See
joining
you
in.
later.
Take care. Bye.